Facebook Live, as well as YouTube. We're going to be doing a talk tonight on the third part of the talk on endometriosis and infertility. So everybody, welcome who's on Facebook Live and YouTube. So glad you guys are here. We're going to be doing a talk on endometriosis. Hello, Rosamine. So everybody who's on Facebook Live, who's on Instagram, sorry, jump over to Facebook Live. We're going to be doing a talk on endometriosis. Welcome, everybody. Hi, Peekabook and BJ Pumpkin. Jump over to Facebook Live. We're going to be doing a talk on endometriosis, the last part in my series. We're going to be talking about the impact on infertility. It's going to be more oriented towards IVF. In other words, how does endometriosis impact? Hi, Tara Shank. Good to see you on Facebook Live and YouTube. So everybody who's on Instagram, jump over to Facebook Live. We're going to be doing about a half an hour of talk on endometriosis and infertility. I'm Dr. Magarelli, CNY Fertility, Colorado. Welcome, welcome, everybody. Hello. So as I'm telling everyone, we're going to be live on, let's see, I'm not seeing many comments there. Let's see. Where are my lovely people? Say hello, everybody. Say hello on Facebook and YouTube, because I'm only seeing Tara. Hi, Tara. I hope it's not a problem with my, let's see, is sharing your screen. Okay, good. Hi, Judith. Hey, Katie. So everybody who's on Instagram, jump over to Facebook Live. Hi, Crystal, Natalie, nice to see you. Indiana, nice to see you. Molly Hanlon, jump over to, if you're on Instagram, jump over to Facebook Live or YouTube Live if you don't have Facebook. Oops, stage 4, endometriosis, first failed frozen embryo transfer. Sorry, Tara. We're going to be talking about endometriosis and infertility, specifically about the impact on assisted reproductive outcomes, PGT-A, those kind of things. As you all know, I've been over the past 2 or 3 months talking about endometriosis in 3 parts story. I'm going to summarize at the end of this discussion what I've learned. So all you folks on Instagram, jump over to Facebook Live and or YouTube, the CNY Fertility channel. I'm Dr. Magarelli. Hello, Chris Parasoto, Shannon Latoya Holmes, hello, Razan Dazugi, hello, Judith Glant, hello. Hi, everybody. It's a pretty cold day. As a matter of fact, I don't know if you guys can see it, but all the windows in my little out place where I have my office here all steamed up because it's so cold outside here in Colorado. All you folks on Instagram, just jump over to Facebook Live. Hello, Natalie. Will you be covering adenomyosis? Not at all. I did a whole talk, Natalie, on adenomyosis. Just look at our library on CNY Fertility Facebook. All the talks I've done, and I did a whole one on adenomyosis. Why do they see endometrioma but no signs of endometriosis with laparoscopic surgery? Well, I'll actually answer that while people jump over from Instagram to Facebook Live. Well, because endometriosis, as you saw in my very first lecture, can be almost invisible. It can be completely clear on the peritoneum or lining of your uterus, but once it's inside the ovary, it can create these endometriomas. So let me get started with the talk today. And then everybody who's on Instagram, jump over to Facebook Live or YouTube. So one of the key things that is very important to me, and I think I'm going to get rid of my brand off here. Hang on a second, guys, because it's really, let's see if I can get a nice blank one. Actually, I don't know how to do a blank one. Maybe I can just click off that one. There you go. I think that's a little easier to see. Is that when we're dealing with endometriosis, as in all aspects of fertility, the key issue is cost. And what is a cost-effective way to manage patients? So all you folks on Instagram, jump over to Facebook Live. because I'm going to be talking, and you can see it on Facebook Live or on YouTube Live, and then I'll jump back to Instagram a little bit later. But anyway, so we're always thinking about cost effectiveness here at CMY, and that's because that's our niche. I mean, we're geared towards making priceless affordable. In other words, that beautiful baby that you would like, you want to make that, that dream you have, which is priceless, but you have to do it in a way that's affordable to you as a couple or as an individual. So one of the topics that I want to talk about today is does endometriosis impact IVF-PGT-A outcomes? So this is a very large, by the way, as you know, I try to do only 2021 studies or 2020 studies or 2019 studies. I don't go back 20 years. Infertility that's on, the information that's on the internet tends to be 10, 15, 20, 30 years old. And unfortunately, that was when we first started, didn't know very much. And we know a lot more now certainly about disease states. And so in this most recent Fertility and Sterility, which is February 2021, this was a study looking at how the diagnosis of endometriosis can impact the outcomes in IVF, and is it via oocyte quality or endometrium? We don't know where in the process of implantation endometriosis interferes. But by controlling, in this study, for the embryo quality, by using only euploid frozen embryos, they found absolutely no difference in pregnancy outcomes in patients with endometriosis compared to patients undergoing treatment for male factor and non-infertile patients. In other words, the mere presence of endometriosis with a euploid embryo did not interfere with the implantation of that an ongoing pregnancy and the outcomes. So this would suggest that possibly endometriosis does not have an effect with those embryos that are chromosomally normal. This was a much bigger study. This was published 2017. And what they looked at was, does the impact of endometriosis impact IVF outcomes? So this is a more general study. It's not PGT-A. And what they found is if you looked at all the groups, there was no difference were observed between the groups in terms of live birth rates, clinical pregnancies, or miscarriage rates. In other words, compared to those who did not have a diagnosis of endometriosis, the endometriosis did not seem to have an impact in this study. What they did find, though, was there were a lower number of fertilized oocytes, lower number of actual oocytes, but of the oocytes that they did collect, the fertilization rates were the same. They did not find that there's an age component relationship between outcomes and having endometriosis or not. So that means between below 35 and over 35 to 40, there was no difference. So they found that fertilization rates is not impaired and the likelihood of achieving a live birth is not affected. So this would suggest that there's not a direct effect of endometriosis on the end result post-fertilization, but there may be an effect on the total number of eggs one gets. So therefore, fewer eggs, fewer embryos, and statistically that would lead you in the right study to fewer pregnancies. So again, it may be that endometriosis is affecting something in the ovary. Then the question was, what happens if you do surgery for endometriosis? Does it in turn have a negative effect on the outcome? Well, this is an interesting study. It was a big study, about 733 pregnancies and about 566 deliveries and 500 babies. What they found was that, and listen to this carefully, what they found is that women who had endometriosis tended to have small for gestational age babies and preterm babies if you had a history of surgery for endometriosis. However, here's the problem. A high rate of conception in this study were done with IVF patients, and IVF patients tend to have small for gestational age babies, and preterm deliveries. So the problem in this data is that the study, although fairly recent, this is 2020, it wasn't clear whether having the surgery is going to have a negative effect, more so than simply doing the IVF itself. So this is a SART review, and this was looking at quite a few tens of thousands of cycles, and they looked at cycles of patients with endometriosis. And again, the conclusions were that you had fewer eggs, and in this very large study, they found there was a lower implantation rate, lower pregnancy rates after IVF. However, it was confounded by many other variables like male factor, tubal factor, ovarian reserve factor. But I think this, of all the studies that I've read, would suggest that endometriosis does have an alteration somewhere in the reproductive tract, whether it's the uterus, whether it's about whether it's in the level of the ovary, the oocytes themselves, whether it's implantation. This would suggest that it isn't in your mind that having endometriosis and you seem to not get pregnant, or you have less of a chance to get pregnant, you're probably correct. They've not been able to tease this out because there's many concurrent other problems associated with endometriosis, and it's very hard to study it in isolation. But at least what it suggests is that we should manage the endometriosis. Now, the surgery doesn't seem to have a untoward effect, so doing surgery for endometriosis, that's probably a good idea. And there are many different medical managements for endometriosis: Lupron, Orilissa, GnRH antagonists, GnRH agonists. So managing the endometriosis, if there, is probably a good thing. So should you do surgery or IVF first? So this is a debate, and it had a lot of very strong reproductive endocrinologists in the field, very well known. And on those, I'm going to summarize a very big study. And what it said was, the answer is, so it's a debate. So on one side of the debate, it said, yes, you should do surgery first. And at Duke University, where I went to school, that was what they taught us: do surgery first, ask questions second. And the reason for that is that you might, as the other data suggests, is that endometriosis may reduce the likelihood of implantation and the likelihood of oocyte yield and a lower pregnancy rate. And so on that side, you would say, well, if you had a polyp, of course you'd do a surgery, or if you had uterine problem, you'd do a surgery. Why wouldn't you do a surgery for endometriosis? So that was their premise. But on the other side, there was the other team of people suggested, and all you guys are on Instagram, jump over to Facebook Live. I'm doing a little bit of a lecture, and then I'll come back to your questions here shortly. So jump over to Facebook Live or YouTube. So those who said, no, don't do IVF first, they felt that it would be, there really aren't strong studies saying that surgery is better. So their process is, well, why do harm? And let the doctor and patient decide. And why did they say don't do harm? Because unfortunately, surgery can lower ovarian reserve simply by the destruction of the ovary during the surgical process. It certainly does not increase outcomes. That's what they've found. It should be done if pain is involved. In other words, yes, do surgery first if you have endometriosis and pain, but it suggests that you should not do surgery first if your goal is a baby and you don't have pain. Okay? So that's kind of how to interpret that data. So is it endometriosis? So about 40 to 60% of women who have severe menstrual cramps have endometriosis. 70% of women with chronic pelvic pain, they have endometriosis. If it's in a first-degree relative that who has endometriosis, then you're likely to be a candidate. Up to 50% of women with childbearing age worldwide have endometriosis. That's 1 in 7, and up to 40% of couples who've been defined as infertile will have endometriosis as a diagnosis. So it's something very ubiquitous. Pharmacotherapy, the question was, well, how do you treat this medically? Well, there's no pharmacologic agents that improve fertility outcome in the setting of endometriosis. In other words, all they do is mitigate the pain. You can use birth control pills. You can use non-steroidal anti-inflammatories as empiric therapy even before you do surgery. There's no data to support using Lagolix over birth control pills or progesterones. In other words, yes, it's a newer drug or Alyssa, but it doesn't necessarily mean it's a better than birth control pills or GnRH agonists. Postoperative treatment with progesterones or birth control pills for up to 2 years resulted in reduced cyclic pain and endometrioma recurrence. So a lot of times we'll recommend you go on Lupron or long-term suppression, but a lot of folks want babies. Second-line therapies include GnRH agonists, antagonists like ganirelix, Lupron, aromatase inhibitors like letrozole and anastrozole. Oral androgens don't seem to help, and they are looking at immune modulators as a way of helping. This is a summary of a previous slide that I talked to you guys about in recognizing treating an endometriosis. When you have a person who has pelvic pain, there's a whole differential. It could be a sexually transmitted disease. It doesn't have to be endometriosis. It could be physiologic dysmenorrhea, painful periods. It could be secondary dysmenorrhea from uterine fibroids. It could be PCOS or functional cysts. It could be an ectopic pregnancy. So just because you have pelvic pain does not mean you have endometriosis. It's a very common disease and has variable symptoms and severity. But if you have the constellation of problems like lower abdominal pain, dyspareunia, painful intercourse, infertility, or cyclic bladder or bowel symptoms, then you may want to think seriously that you may have that diagnosis. Non-steroidal anti-inflammatory and birth control pills, really a good way to take care of this if it's not too painful. And then surgery, of course, is used in those patients who are both infertile and have pain. In a Cochrane study, they looked at acupuncture, traditional Chinese medicine, and what they found was that it was good support for the effectiveness of acupuncture for pain and endometriosis is limited. In other words, we don't have a lot of great studies, but there are enough studies that have shown some efficacy. Similarly, with the treatment of infertility, there's a lot of studies that have shown that there is an effect on improving outcomes with acupuncture, but they're not definitive. We can't do those definitive studies. Are there nutrients that you should be thinking about if you have endometriosis? Well, things like fruits and vegetables, vitamin D3, that's very important. Kiltz's keto carnivore diet, of course, it's very important. Vitamin C and E, antioxidants. Resveratrol, which is it reduces the aromatase, which makes testosterone into estrogen. So that's like an aromatase inhibitor. It reduces pelvic pain, dysmenorrhea. So yes, there are dietary approaches that can help you mitigate the pain associated with the endometriosis. How do we in Western medicine approach endometriosis? Well, we bring in the pathologist, the bowel surgeon, the urologist, sometimes even a thoracic surgeon, pelvic floor therapist, pain psychologist, radiologist, and of course the gynecologist who really is at the center. As you can see on the slide, the endometriosis treatment from a pharmacologic standpoint, you deal with some of the symptomatology. If you're having inflammation, you do anti-inflammatories. If you're having spasms, use an antispasmodic. You use vitamins and enzyme preparations. All of these, because endometriosis has such a broad constellation of symptoms and signs, all of these methods have been used. There's no definitive way to manage it. The impact, as I said, of endometriosis on IVF outcomes, the answer is fertilization rate is not impaired and the likelihood of achieving a live birth is also not affected. So this is that big study from 2017. So where does that put us? Well, it puts us in a very weird position because it's almost that surgery for us in the field of reproductive medicine and for you as patients is a diagnosis that typically comes after the testing and after a failed treatment. Many times folks who have a frozen embryo transfer will ask, well, why didn't it work? And I'll go down a list of things that are possible reasons why it didn't work. And one of them is, have you been diagnosed with endometriosis, and have you had a recent laparoscopy? Why? Because in reducing the inflammatory components of it, the mass effect of the components of it, the potential biochemical effects, reducing the number of eggs and implantations, which have been in the SART studies, if we can knock down that disease, we then can additively contribute to possible of implantation being the issue, as well as a mechanical reason being the issue. So it's not fun, to be honest with you, when we're dealing with endometriosis, because it has such a broad constellation of disease manifestations. Certainly, traditional Chinese medicine can help. Certainly, suppression with medications can help. Certainly, surgery can help. But again, it's from the surgical standpoint, you should really try an alternative therapy prior to doing surgery, because surgery itself can damage the ovary, cause a reduction in ovarian reserve, and certainly can interfere with, it may interfere with the egg traversing to the fallopian tube in a natural cycle. All righty, so this is, I'm going to stop here. And as I said, my goal is to answer any questions that you may have. I'm going to change the picture here for just a second. And then we'll start with some questions, okay? Okay. Well, I'm back. Hello, Lindsay. Good to see you. Tara, good to see you. Okay, so let's ask some questions. I have scarred tubes and need a laparoscopy too. I don't know you don't know if you have April, you don't know if you have endometriosis, but they will be able to detect that when they do the surgery. Should I get a laparoscopy after a failed FET with PGT tested embryos? I have blocked tubes. Well, likely, if you don't know why you have blocked tubes, it may be the endometriosis. So yes, I would suggest doing that. Victoria Schmal, hello, hi. Lindsay, you're so welcome. Alyssa, do endometriomas affect fertility, pregnancy, implantation, egg quality? If so, how? Mine are about 1 centimeter. That's only 10 millimeters. 1 centimeter is teeny weeny. I'd be very surprised. That's 10 millimeter. I'm not sure that's an endometrioma, but let's say it is. It can, as these studies suggest, it may contribute to fewer eggs, lower fertilization rate, lower implantation rate, not lower fertilization rates, and could contribute to lower pregnancy rates. So the answer is yes. My FET worked and made it to 6 weeks and miscarried. Doc is blaming it on endo. Tara, well, the doc isn't blaming it on endo. The doc is trying to figure out what is the issue. I mean, why is it that you're miscarrying in the first trimester? Now, the list of reasons, Tara, for miscarrying in the first trimester are legion. There's so many reasons for miscarrying in the first trimester. Can chiropractic care help with infertility? You know, you'd have to ask the chiropractor. My guess is anything can help as long as it reduces stress and gets better blood flow. Hi, Gretchen. Good to see you. Okay. Does endometriosis impact implantation? My RE said that it doesn't, as it's outside of the uterus. No. Well, there's a chemical effect. That's a great question. Endometriosis is on the outside of the uterus, or it's on the outside of the endometrial lining. So it could be inside the muscle of the uterus, which is then called adenomyosis. It could be in the ovary, and that is called an endometrioma. But there is a cascade of inflammatory products that react to having tissue in the wrong place. So what can happen, you can create an inflammatory response to the endometriosis, which in turn can create, and I'll use the term hostile environment for the implantation process, or create invasion of white blood cells trying to take care of the inflammation around the uterus and ovaries, and that can be a problem. Can you take embryo supporting meds in the first trimester? I don't know what embryo supporting meds are. Do you think egg quality can be worse from the side where I have an endometrioma? I think it's more systemic, Judith. What are some reasons for bad quality eggs for someone in their 20s? What can I do to change that? Sumaya, I'm not sure what bad quality eggs are. Thoughts on increasing success with endo and adenomyosis during an IVF transfer? Well, acupuncture for sure. During the transfer process, there's not much you can do at that point. You can, prior to the transfer process, do suppression for 3 months with Lupron or Orilissa. Does endometriosis affect blood flow to the uterus? Are blood thinners recommended? Don't think I have any data on endometriosis affecting blood flow. Got pregnant 3 years ago with an FET and just tried the same protocol, but it was chemical. Any recommendations? Well, if the embryo that you transferred 3 years ago was untested and you won the lottery, which means you got a normal and a grew, that's great, but now you may not. Hey, Alyssa, let's see. I was never able to get pregnant. After laparoscopy, I got pregnant twice. Both ended at 6 weeks. I'm sorry. I'm convinced endo kept me from getting pregnant. No difference in retrievals before and after surgery. And now moving on to transferring my frozen embryos. Angela, I'm so sorry. There's a lot of reasons for implantation failures. Too broad. I had endometriosis removed a few years ago. In the past year, I've had 3 failed transfers. I'm having a laparoscopy, good, and hysteroscopy. If endometriosis is found, will I also need to do medical management? Yes, I would definitely do Terran medical management before your next transfer. Lindsay, Prograf and other meds aren't there some meds so your body doesn't reject the embryo? Are any other meds? Prograf and other meds aren't they the meds so your body doesn't reject the embryo? Well, that's the personification of what we're trying to do with the meds. In other words, reduce the immune response, which might be what you might call a rejection. That's the thinking. Not a lot of studies, or if any studies. What's the best FET protocol for someone that had endo and fibroids removed? Should estrace be avoided, Mimi? No. The best protocol, this is a secret, is estrogen and progesterone. Why is it the best? Because the body has had 10 million years to develop the perfect formula. And that's the formula. Estrogen, then estrogen plus progesterone for 14 days estrogen, then estrogen plus progesterone for 7 days, or a little less than that. Put the embryo in, and you're off and running. Do you recommend a natural modified frozen embryo transfer for those with endo? I don't have that on my radar as a method that helps. I primed with estrogen and progesterone 12 days ago. No period till now. Progesterone level is high. No period till now. What shall I do regarding another retrieval? Well, Rosin, you got to get you got to get that lining sloughed or cleaned. So go to the doc and see if they may want to do another shot of progesterone, or see whether or not your lining is thick at all. What is your opinion on testing embryos? I only have 3 left. Well, if you only have 3 left, I don't know how old you are, but you may want to just transfer them. What's the best med to prime with before retrieving for low AMH? Well, it's estrogen, estrase, and growth hormone. Okay, adenomyosis in anterior uterus graded mild. ERA and endometrial biopsy all came back normal. Current RE doesn't feel it's necessary to do suppression prior to FET. Should I do Lupron anyways? This is Gurn Mountain Girl. 9:30. Should you suppress? But it depends on how many embryos you have left. If it's your last embryo, I would definitely suppress. Nisi, I had a lap in 2013 and was diagnosed with stage 4 endo. I now have low ovarian reserve and a AMH of 0.1. Any supplements that I can take to increase egg quality and quantity? Well, Serovital is a growth hormone secretagogue that you can get at Costco or online. Growth hormone is something we can help, shown to help folks with low ovarian reserve. Vitamin D3 is, we've mentioned before, is vitamin C, vitamin D3, resveratrol. Might want to consider that. I take cabergoline to regulate my periods. Does that affect my chances of becoming pregnant? Not likely. Does 3 to 4 months make a difference in success of egg retrieval at age 35? I may have to delay, and I'm worried that doing it older will hurt my odds. Right, doing it older will hurt your odds, but you may. But life is life. So you can only do what you can do. Don't get too stressed about it. 3 or 4 months shouldn't make a difference. I have a 4 centimeter ovarian cyst and small fluid in the cul-de-sac, and you also have PCOS. Well, why are you starting the cycle? Well, because I have, why are you starting the cycle, April? Why don't you wait a month and see if that goes away? Rosin, do you recommend a third myomectomy? My biggest is 4 centimeters, entering the uterine cavity slightly. Shall I risk transferring or do surgery, then transfer? Rosin, do surgery, then transfer. Are you aware of any studies that analyze the different outcomes of excision endometriosis surgery versus ablation endosurgery on IVF? Yeah, there's no difference. Marlena, does estrogen flare up endometriosis? If so, how would the protocol work with estrase? Well, again, you do the best of all worlds. You got to use estrogen and progesterone to open up the implantation window in order for you to be able to transfer an embryo. Yes, it may aggravate slightly the endometriosis, but pregnancy really is helpful for endometriosis because of the progesterone. So I wouldn't worry about those slight estrase that we give you to get you prepared. ORME is poor response and high abnormals related to endometriosis and diminished ovarian reserve. Yes, very much so. Very much so. Lindsay, I'm sure you're answering somebody's question. Sumaya, I've heard some provider recommending metformin for egg quality in non-PCOS patients. Is there enough research to back this up? Not that I know of, Sumaya. Amira Ortiz, my last progesterone came back at 123 at 4 weeks. Should I keep doing the same dose of twice a day and 1 ml injection, or cut it in half? I wouldn't change anything until you see a heartbeat, okay? You said at 4 weeks. Yeah. So I don't know if you've seen a heartbeat. Don't change anything. Jordan, do you see higher success rates with FET after suppressing with Lupron or Orilissa after a lap? Yes. The answer is yes. By suppressing not a lot of good studies, but there are studies that show it's better. Hi, folks on Instagram. You can ask any questions too. You don't have to just watch, but I'll read the questions from the Facebook Live and the YouTube Live. Okay, do you recommend Lupron and Letrozole before FETs with endo? I do not recommend Letrozole. Vanessa's back. Please feel free to join the CNY Fertility Support Group. Please do that. Marlena, I had laparoscopy and hysteroscopy 2 weeks ago. They found endo. How long do you usually recommend being on Orilissa and Letrozole for? Well, okay. I'm a little... Well, I think, if I'm not mistaken, it's 3 months. I don't tend to do that protocol. Courtney, is a gestational sac measuring 5 weeks, 6 days without a yolk sac or something you would worry about? I am technically 6 weeks, 2 days at time of scan. I also have second gestational sac that is much smaller, Courtney. We should be concerned, meaning we should monitor you closely, but Worried, I wouldn't use that term. How common is endometritis? Do you recommend endometrial testing? This is 35 pineapples. We do endometrial testing for endometritis when we do hysteroscopy pretty regularly. Okay. Why do you not recommend letrozole? Well, I don't recommend letrozole for frozen embryo transfer cycles. That's what I'm not recommending. But for suppression before the cycle, so I'll fix that when I just said. Suppression for the 3 months, yes, letrozole, that's fine. But during the cycle in which you're going to get a transfer, do not use letrozole, in my opinion. Endometriosis patient, 2 IVF cycles, 7 IUI fail, low egg reserve, planning to do another round of IVF. Okay. Is there a deciding factor for surrogacy if age 30 with endo and adeno, diminished ovarian reserve due to surgery and blocked tubes due to endo? Well, a tour de force, have you tried using your own eggs? I mean, you should try. Ultrasound showed double layer thickness at 13 millimeters. That's beautiful. What can I do for optimal lining? So is that double layer or trilamina? Yeah, you want it as close to 3 layers, I guess. I call it Mick Jagger's lips. It has a line, and a line. That's what you want it to look like, is Mick Jagger's lips. Why not for frozen embryo transfer if you're doing natural FET pregnancy? I don't know what the question is. That. Okay. Mental letrozole. Still not sure. Is letrozole best for IUI for endometriosis? I don't think anybody's looked at that, but that's an interesting question because it is an aromatase inhibitor. So it may be if you're doing IUIs. She said double layer thickness. That means it's not trilaminar or it's already becoming homogeneous. You want to ask her more questions. I have 10 millimeter cysts, which doctors have labeled endometriosis. I don't have any symptoms. Are there any protocols I should be following to prepare for IVF? Well, go back over the 3 talks I gave on endometriosis on foods, acupuncture, supplements. Do you recommend hysteroscopy after a failed transfer of a mosaic embryo? No. HSG and SHG were clear. No. Chloe's baby journey, no. Why can't you use letrozole for FET transfer if you're doing a natural FET? I don't know that. There was a recent study that showed that adding letrozole to IVF cycles lowered frozen embryo transfer cycles, in that study, lowered reproductive outcomes. So I'm concerned. So I'm doing a lot of homework trying to understand the mechanism by which in a frozen embryo transfer cycle, there seems to be a decrease in reproductive outcomes. All right. We had ovarian drilling done about 4 months ago, still did not ovulate. Any suggestions? Don't do the drilling again. That would be my first suggestion because it can lead to uterine, to pelvic pain, scarring. And you could do suppression using birth control pills to at least, I'm sorry, you can use dexamethasone to reduce the androgens, which was exactly what that little holes in the ovary was doing. For frozen embryo transfer, estrogen plus progesterone. That's it, folks. That's what nature has done for 10 million years, is estrogen plus progesterone is the best treatment for a frozen embryo transfer. All the rest of the stuff are icing on the cake. But estrogen plus progesterone and maybe baby aspirin, that's the base. But the estrogen and progesterone just mimic what nature has been doing for 10 million years. And I kind of trust nature. I had a baby with CY, thinking of doing another FET this winter or going natural, whatever works. Can I take Serovital now? Yes. Yes. How long before? You should not stop serovital. You don't have to stop serovital. I had a canceled cycle in October. Started microdose Lupron last Monday in anticipation for my next cycle, which is due to start tomorrow. Without a bleed. Can you start a stim without a bleed? You absolutely can start a stim without a bleed. As long as your lining is thin and your estrogen and progesterone are suppressed, then you should be able to start. My HCG on 13 days after FET is 1,600. Is it possible that the embryo splits since the HCG is high? Yes, Jamie, it is entirely possible. I wish you the best. I wish you the best. Folks, that's why I always recommend transferring one embryo. I've transferred one embryo and gotten triplets, 2 embryos, gotten octuplets. I put the octuplets up. So you really want to transfer one embryo typically. If you transfer more, what happens is you get more multiples, not more pregnancies typically. Good evening, Dr. Mag. You did my egg retrieval on the 12th of October. I am doing an FET, and my first FET failed. Any other suggestions? Z-Pak, prednisone, LDN, estradiol, progesterone. Would you suggest an HCG wash, not HSG? Acupuncture, low carb eating, serovital, growth hormone. That's what I would recommend, Cassie, if you've had some failures. Can we start stimming medicines without having a period? Yes, as long as you meet the other criteria, which are you don't have a cyst and you don't have a physiologic cyst producing estrogen and progesterone. Is there a chance we could request you for a transfer? Sure, if I'm there, absolutely, please do. Is Omnitrope basically the same as serovital? No, Alyssa, Daniel. Omnitrope is the actual growth hormones. Serovital is a group of very special amino acids that cross the blood-brain barrier and help your body to secrete more of your own natural growth hormone. They both, the goal, of course, is to produce more growth hormone. Does CMY take United Healthcare? I don't know that, but you can call our financial office. It is very, very, very likely that we do. Very baby onboarded that we do. Massage with Liz joined. Nova Ashley joined. Hello. Slowing down on the questions. Where are you folks? Thank you. Okay, good. Any question? Let me see, make sure I'm not. Okay. How long should you be a stim cycle at best? Mine was 20 days with no normals. Well, Urmi, the issue isn't how many days, it's how long it takes for you. Okay, Lindsay said we do take United Healthcare, just so you know. The length of time in the follicular phase doesn't matter very much. It's the post-follicular phase that matters. So that's not likely the reason why you didn't get normal embryos. Okay, Rosin, I answered this question before. Can we start stimming meds without having a period? My period is late. Yes, you can, as long as you don't have a cyst. Hi, my dear daughter, Amber Kelly Martin. Hello there. Kiss, kiss. Hi there. I don't know if you're there, Brady. Hi, Brady. That's my grandson. Heather Page. Good to see you, my dear. All right, Nova Ashley, I'm planning to do my first FET in December. When do I start the antihistamine protocol? Very soon. Call them up. You should be doing it soon. Is it likely to have a successful transfer after 3 times with the euploid embryo? Well, please find out why, like, for example, if you have a euploid embryo, which means a normal embryo, do an endometrial reserve test, do acupuncture, do low carb eating, serovital. Let's see. Have you seen anyone who has opposite or negative results with Omnitrope? Nope. Where do you like CA2025 to be, and what are you testing with it? Oh, no, Judith Glantz, you don't want any CA125. That is a tumor marker. It could be a cancer marker, but it could also be a tumor marker. You don't really want to have that. Heard about, see what? I heard so much about CNY and had two friends go to the office in New York City. Well, in New York State, not New York City. All right. How long do we wait between egg retrieval and open myomectomy? I like open myomectomy, probably 6 to 8 weeks. But I would absolutely do the egg retrieval first, okay? Cassie, looks like my FET is possibly the second or 15, 16s. Whoosh. Wow. Okay, acupuncture is something that you do. It's called the Credenda Magarelli Acupuncture Protocol. Diane Credenda and I developed the protocol. She's the, really, we started the research 20 years ago, thanks to her, on combining acupuncture with IVF. And that's her lovely picture right over my shoulder right there, because now she's my lovely wife. But acupuncture is a protocol. And if you don't know where to go to the American Board of Oriental Reproductive Medicine, ABORM.org. And or you can go to the Healing Arts Center if you're close to one of our centers in New York. Is norethindrone good to take to suppress endometriosis while waiting to start an FET and before taking the transfer? Sarah Lee, absolutely yes. Katie, I'm planning on doing an FET in November. Do the holidays affect transfer dates at all? We just don't work Christmas Day, New Year's Day. Not New Year's Day, sorry. Thanksgiving Day, we don't work, and Christmas Day, we don't work, and Sundays, we don't work. So if you're on one of those days, it'll be adjusted, okay? What is the percentage of miscarrying a PGS normal that implanted? Thanks. This is Jamie. It depends on how old you are, Jamie. What is the waiting time for embryo adoption? I actually don't know. I would call our donor program coordinators, the 800 number for CNY fertility, and ask. Planning on doing, oh, we already said that. I'm not sure that Cassie, what you're asking about the 12th. You're laughing, but I'm not sure what it is. How long should we wait between egg retrieval and open myomectomy? So you did an egg retrieval, and then you're going to do an open myomectomy next. That's the right order to do it. Just the next cycle is fine. Is Mediterranean diet a good diet for fertility? Absolutely. Look at all those Mediterranean Romans roaming around. That seems to make reproduction pretty good. We are scheduled for your office for a consult in February. Do you recommend any vitamins and supplements? Absolutely, Killsy Bernie. Download our family building guide, which you'll find at CNY Fertility website under the resource page. Please review that, guys. It is super informational. We just updated it. Do start acupuncture now. Start Zero Vital, which you can get at Costco or online, SEROVITAL. Does Orilissa or Lupron Depot affect egg quality? Not that we know. If I would need to have another retrieval in the future after suppressing for 2 months, it is more likely to help than to hurt, Jordan. Okay, so yeah. Lacienne joined. Hello, Shout of Perfection. You're very welcome. Lindsay, did I get your question? I think I missed that, Lindsay. Do you have a satellite monitoring facility in Ontario? No. Do I have to decide on genetic testing before arriving for retrieval, or can I decide based on the amount of eggs at the time? Well, Queen Nick, you should decide 2 weeks before you even. Actually, you should decide at STIM start that you want genetic testing. Then you could decide against it, but if you want genetic testing, say yes. There's going to be fees to pay. There's going to be consents to do. But to do it at the very last minute, I will tell you, nobody likes that. Is frozen sperm as good as fresh sperm? Yes, for egg fertilization. How often would one have to come to the office at flying in from California to Colorado for IVF? Well, if you're doing IVF to get to retrieve the eggs and put them back in, anywhere between 3 and 5 days. If you're doing IVF to do genetic testing on it, 2 or 3 days. Any benefit for men taking Serovital? Absolutely, because 50%, guys, of getting a baby is the sperm, and 60% of miscarriages are the sperm, so you want healthy sperm. No alcohol, no tobacco, no drugs, no smoking, no marijuana, all that stuff. You're welcome, Shay. You're welcome. How are we doing here, guys? Let's see. We're doing good on time. Lots of good questions, and I hope you enjoyed that acupuncture talk. I have them all recorded for you. Okay. I typed wrong. The 12th of November. So we'll be seeing you again soon. Sorry, I'm planning on doing acupuncture in Colorado before either with you or Dr. Fink transfers my 2 remaining. Then, unfortunately, we will retrieval again. So, Cassie, start your acupuncture now. You can't have too many treatments. How often would one have to come to the office if flying in from California for IVF? I already mentioned that. It's 2 or 3 days if you're going to freeze the embryos. It's 4 or 5 days if you're going to transfer the embryos. So that's a rule of thumb. All right. We are dwindling here. Hi. After all the analysis done, how long does it take to do the IUI? We could do the very next month. And do not do more than 3 IUIs without getting another doctor appointment because it should work. Is PGT suggested if no history of genetic disorders? Absolutely, Nisi, because PGT is not for genes, which is what a genetic disease is. PGT is for chromosomal abnormalities like Downs, which are not inherited. So you're looking for problems with the embryos, building blocks, not with the genetic makeup. Okay. Oh, Cassie, it's my pleasure. Does endometriosis come back, and how often should surgery be done? Absolutely. You never get rid of endometriosis ever. That's the key. You suppress it, but you never get rid of it ever. Yes, it is likely at some point in the future, especially if you have a long reproductive lifespan, that you will have to have another surgery. It is just a function of, unfortunately, it's like a weed. No matter how many times you do the surgery, how many times you weed the garden, weeds come back. It's exactly a good analogy. Okay. Dr. Mag, you are more informative in explaining on lives than over the phone and when meeting you in person. Enjoying listening to you. Wait a second. Is that a compliment, Rosin? You are more informative in explaining on lives than over the phone and when meeting you in person. So, well, on lives, I have an hour to talk to you guys. What do you recommend I do before flying in for IVF consultation? Had 2 IUIs. What do I recommend you do? You don't fly in for an IVF consultation. That's all done through the video. Can I fly back home the same day of retrieval? Queenic, please don't. Everyone who has your retrievals and transfers, please rest for 24 hours before you get on a plane. Why stress yourself out? If you don't know that flying is stressful, it is. So please give yourself at least 24 hours. Vanessa says, join the CNY Fertility Support Group. Are 3 IUIs also recommended for those with endo? I had 1 unsuccessful IUI already. Should I jump straight into IVF or try again? I'm 30. I would definitely try again. At least do 2, if not 3. Do you recommend Duostim? I'm a poor responder. No, I actually recommend back-to-back for poor responders. I have rheumatoid arthritis. Is it likely to be a reason that my AMH is low for my age? No, but check. Same thing with flying after FETs. Please give yourselves 24 hours. Please give yourselves 24 hours, please. Rheumatoid arthritis is an inflammatory process, sometimes associated with Hashimoto's thyroiditis, more likely to be a cause of low AMH, but any kind of immunologic disorder can and does interfere with ovarian reserve. That's a good compliment to you, sir. I said thank you and put a heart emoji. Good. I'm glad, Rosin. Thank you. I just misread. I was just pulling your leg. Okay. But thank you for the compliments. Should I try IUI at 43 with a 0.67 AMH, Heather? My recommendation in that circumstance is look at your finances, look at the time, look at the investment, And that's how you're going to decide. And unfortunately, your biology is very difficult, age as well as AMH, so it's a challenge. And really, those are the factors at that point. Now, it doesn't mean it doesn't happen. It's just a challenge. So it's a challenge. Transferring 2 versus 1, I would much prefer you to transfer 1. The data is strong that transferring 1 is a good idea. 2 only increases your chance for triplets, quadruplets, quintuplets, octuplets, and I've certainly seen that. How long after a consultation does it take to get a physical appointment? I think what you mean, Shay, is that you want to be seen for treatment, and it's usually 6 to 8 weeks after your consultation. You'll get to the point of starting the treatment phase. So you figure 6 to 8 weeks, which is 1.5 to 2 months. Sometimes it takes 3 months. Got it, Shay. Good. All righty, we are gradually running out of time. I've got a few minutes here. We are going to be doing next week is my Q&A, just questions and answers. So the goal there is for you guys to bring questions. What was my big learning this week? Well, I got to tell you, the nicest thing is I'd like to do a shout out to all those wonderful nurses that have flown in from Albany and from Syracuse to help us as we look to add more nursing to our program. So they're here to train us. We are looking for nurses. We are looking for medical assistants. We are looking for doctors, especially reproductive endocrinologists. So if you got brothers, sisters, aunts, uncles, cousins, and who want to work for CNY, it's a wonderful organization. We're looking for nurses up in Rochester. We're actually looking for nurses everywhere. We are growing. So we ought to thank Meg for coming out, a wonderful gal, helping us with just our organization, and certainly Amber and Amanda, I did that again. Amanda, for coming out and helping us. And of course, we always love it when Dr. Banerjee jumps out. I want to thank Dr. Fink, man. He's doing a phenomenal job. Wish there was an office in Los Angeles, Shay. Your wishes may come true in a few years. So anyway, thank you all for sharing this evening with me. I sure appreciate your questions and your paying attention and always challenging me to try to figure out a way to make it more understandable. I love teaching you guys. I love teaching everybody about this lovely field. Think pregnant thoughts. Your body actually demands that you get pregnant. You're not fighting nature. You're really just we're just finding a mechanism, a way, a trick to get through the forest of confusion so that we can get to the fields of understanding. That's really what we're trying to do. And we always wish you the best. It may sometimes seem hard. You guys are all welcome. Please send us questions. If you have something positive to say, please, if you can, spread the word on the various social media sites. If you feel like we're doing a good job. If you feel like we're not, just contact us. We'll try to fix it. That's the one thing that this practice really is about. As Vanessa Rodriguez says, feel free to join the CNY Fertility Support Group. She has that listed on Facebook. I'm sure it's on YouTube. You Instagram folks, thanks for sticking with this talk. All of these talks are recorded, and you can always follow up and learn more about it. Anyway, have a wonderful evening. Thanks for being part of my life here, and I look forward to seeing you in person. Thanks, guys. See if I can find you here. There we are. I feel like I'm following a bug.